Thank you. Good evening. This is Dr. Ajoy from Kolkata, India, and I'm welcoming you all to this evening webinar, a little bit of exchange of our knowledge and the first knowledge on Rayner, the RayOne EMV lens. Now, before I start, please excuse me as my video is somehow technically not working, but anyway, I'll be there audio available. So we have the Rayner team. Along with that, the three speakers, Dr. Stuart, Dr. Nivean, and Dr. Ryan.
Thank you. Thank you for that kind introduction. Thank you for Rayner for having me. So the EMV lens, well, firstly, it's important to state that this is very much a monofocal lens, and therefore it's not associated with the well-documented side effects that multifocals are associated with, like reduced contrast, night vision disturbances. What the EMV does, that's in addition to a standard monofocal, is that it increases the patient's depth of field through spherical aberration induction. So for that reason, it can be used to give patients what's referred to as monovision enhanced or a modified monovision setup. So before I discuss this, I thought I'd go through the well-documented drawbacks and limitations of monovision. So they're well known, well documented. The first of them I would say would be intermediate vision loss. And that's quite simple because you've got one eye for distance and one eye for near, and so nothing covering intermediate. So patients with a monovision setup with standard monofocal lenses will complain of poor computer distance work. There are tolerance issues because the two eyes are so far apart with that anisometropia. Only about 60% of patients can tolerate the standard monovision setup. Patients complain of a distance vision loss. That is to say, they feel like they've given up some of their distance vision to gain reading. And because of the two eyes being separate, again, there can be summation loss. There also can be a breakdown in stereoacuity. So that's due to anisometropia. If you go too far with that anisometropia, patients lose their stereoacuity. And studies have shown that can be irretrievable if that's broken for too long a period. So the EMV lens comes from a lot of hard work by Professor Graham Barrett in Australia and his work with the clinical scientists at Rayner to develop this lens. Now, how it works, as I say, is by inducing a positive level of spherical aberration. So spherical aberration is a higher order aberration, which in two higher levels in patients' eyes is associated with night vision problems. So this is the reason why patients in the late 80s and early 90s with very small optical zones in laser procedures with PRK had terrible night vision. But it's through Professor Einstein, who's my boss, through his work with repairing patients like that, that he found that there were levels of spherical aberration that you could almost term therapeutic, where there was a toxic level that if patients had spherical aberration levels above this level, they start to get night vision problems. But below that toxic level in the therapeutic range, the patient tolerates it with no night vision disturbances, and there are benefits. That benefit is an increased depth of field, and it works through increasing a patient's depth of field through the process of a circle of least confusion. So instead of having a sharp focus that you have with a standard monofocal, if you increase the spherical aberration, there's a circle of least confusion. That's where the depth of field comes from. So what does that mean for the patient? Well, it basically means that the reading vision of the distance eye will be better than with a standard monofocal set to planar. And the distance vision of a reading eye set to say -150 will be better than with a standard monofocal. Why is that? Well, it's because the spherical aberration allows edge detection. It allows the blurry image to be processed. If you then combine that with a reduced pupil size when patients are looking close up and accommodating, and then central neural processing, they can take what would be a normal, very blurry image with a monofocal set to -150 and sharpen it and be able to process it. So I explain this to patients as if you take standard monovision setup, they have one eye for distance and one eye for near, and the two are totally separate. There's no synergy between the two, and that's what gives rise to the tolerance issues. When you have spherical aberration induced in that setup, you've got a little bit of wiggle room in each eye. That depth of focus means that now the distance eye will do the majority at distance, but it will get assistance from the reading eye and vice versa. And so because of that, there's then synergy between the two, and the tolerance goes much higher. It's 98% of patients will tolerate a monovision setup when you've got spherical aberration incorporated in it. And then we get round all the other problems that we stated just before. So I've been using the EMV now for probably a little over 6 months. Pretty small numbers, but I've been using it with a monovision setup. So I target the dominant eye to distance and then the reading eye to -1.5. And the results have been fantastic. I think we'll come to some of the results a little bit later. But that's the principle of the lens and the way that I use it.
Thank you, Dr. Stuart. I think you gave a good intro to this, the whole concept of this lens, how this lens should change the way we do. I mean, most of our surgeons will be doing this monovision, and the whole concept how this lens differs from the other way that we do, where the two eyes are disjointed. We are combine that, and we'll come to the next speaker. Is it Dr. Nivean?
So thank you, sir, for this kind introduction, and welcome, Stuart. It was nice seeing you. I saw your session on ESCRS, so that was a really interesting one. So I'm just going to show something different. I think I just have a surgical video of my first case of Rayner EMV, because we started using these lenses only 6 weeks back, and then a short study of our 10 patients that we had. Yeah. So even though we're all cataract surgeons, there are some basic principles that goes well with all cataract surgeries, I think, to get a good rhexis, because all these lenses, I think a good centration is required, and also that we need a good overlap of the anterior capsular margin to make sure that the lens is stable. So always aiming for a 5 mm rhexis. We use the capsular needle here. You can also use the forceps, I think, whatever the surgeon is comfortable with. And then in our institute, we use a standard 2.8 mm keratome. But I think this new cartridge is actually even sub 2.2 mm cartridge that they have for this new Rayner EMV loaded lenses. So just a good hydro dissection. You can see the fluid wave that is crossing across and a slight tap in the center to make sure that you don't overfill the bag. I just run through the videos over here. I usually do a stop and chop technique. So basically make a groove in the center, and then once you reach the adequate depth, crack it into 2 halves, and then you have 2 hemispheres here. You can see the crack going all the way across. And then it is broken down into the smaller lens. So since we were excited about this lens, we also took an outside video shot of the same surgery. So we tried to combine the external view also, because we wanted to know how the delivery system works and how the cartridge and the lens injection is. So on the left, you can see the external video of the same phacoemulsification that's going on. So the next key thing is a good cortical aspiration, and then after that, even removing all the small fibers that are rather in the PC. For any premium IOL, that I think we'll all agree that any of the small pearls that are there in the PC or these types of fibers, I think, should be removed entirely, because that can also cause an hindrance. Even though you have a beautiful lens, I think a beautiful clean surgery is also a very key important factor that plays here. We can also use a hydrojet cannula to actually release these fibers, and some amount of polishing that is done. And then moving on to the injector, that what we found different, it was a very easy cartridge and an injector to use actually. So it had only 2 steps actually. That's just very simple and a very short learning curve compared to some of the other things where you had to put the plunger and then inject. So just inject viscoelastic through the port that's available there, and then just clip the lens. So it's like just the 2 steps of whatever they call it. So it's easy and it's fully preloaded, no touch technique. And then they also claim that one hand, it does make a difference, because I usually deliver these lenses through the irrigation on my left hand. I don't use viscoelastic, so you can see the irrigation on my left hand. And that's how I inject these lenses. And yeah, it goes sub 2.2, so it was not very difficult when I have a 2.8 mm incision. I think talking more about the design, I think these haptics are also nice and flexible, so they prevents PCO. So that was our first implant and our first post-op day picture, and we were also surprised to see the results, to have a good distance vision and also near vision actually. So that is what was surprising to us. And just to add here that initially when we started the study, we actually did it on monofocal patients, because any new lens that comes, unless we try it out and we are sure about the outcomes, we don't actually promise to the patients. So you still follow the same practice of under-promising and over-delivering, and to understand how it works before actually telling the patients, because then the expectations becomes too high here. So then I just share the other slide where we have a small data. So ours was a very short study. I think, as I said in ESCRS, the doctor understands the whole concept that you have a single focus lens that works only for distance vision, and then you have the trifocal range that covers all the distance. So we are talking something about an increased range of focus. So once we understand that, I think it's easier for us to talk to the patients and also suitable candidates for these types of IOLs. So actually the first phase of the study, we targeted emmetropia because I wanted to know how the lens works actually before going to a slightly myopic shift. So we did have very good results as far as the vision. It was actually surprising. So we haven't had the last follow-up yet because we are still in the process. So I don't have my complete data to share with you. I'm sorry for that. So, but in my short clinical experience, so everybody asks me, where do I position this lens? I think in my practice, we had the monofocal, and then this last few years, I think it's been more of a trifocal practice. I think it's different in Europe and other countries. I think you have more of trifocal practice and people have accepted that. The only difference is the multifocal and all the problems have come down, and that is the gap that is there, and all these extended range of vision lenses are in that market. But I would actually say Rayner can actually replace the monofocal market because it gives something better to the patient. So when they can get something better, I think they deserve it. So I think it goes into both the markets where you have intermediate and decent amount of near vision. So yes, I agree totally with as he said that it gives definitely something better than what a monofocal would give them. There is no question about contrast because there's no loss in contrast because you don't have the rings. No complaints of dysphotopsia. Yes, the patients are very well aware of how the rings work in multifocals, so they really know. And as far as there's no complaint from the patients, the doctors are also happy with that. I think that's the most important thing. And one more thing, I think what was spoken also was the certain category of patients who have glaucoma or also retinopathy. I think these lenses are forgiving and they can be used in these conditions also. Dry eye, which is also contraindicated in most of the trifocal lenses, I think it can be treated. It may not cause that amount of problems that a trifocal lens or a multifocal lens would cause. And yes, pupil independent. So yeah, so this was also one of the offset case in which the patient was a glaucoma patient, and also we had a low power, 13 power that was actually placed, and the patient had really very good results. You can see the 6.6 N6 was there for the patient, isn't it? And we're also mapping the EDOF curve for these patients to see, and later on compare with the other EDOF lenses or the trifocal lenses to show how long that, what else said about the range of vision or depth of focus. So how much can they hold? So I think that's going to be the new normal now. So it's like combining the best of both the worlds, because that's how I was presenting before. And this is how I'm sitting in my clinic and presenting now. So things have changed. So it's great for distance. I think there's no question about that. Intermediate, it definitely works. And I think bilaterally, as he said, if he can give a good depth, I think it is really a great lens for the future. Thank you.
Thank you, Dr. Nivean. I think that was a wonderful talk where you described how your first-hand experience was after that short intro by Dr. Stuart. Now let's go back to Dr. Ryan D'Souza. Now he would explain to us how this thing is working. You are not using a trifocal, you are not using an EDOF, you are using a simple monovision lens, and still you're getting this good. Yes, Dr. D'Souza, let's hear your presentation.
Thank you for that kind introduction, Dr. Paul, and thank you, Rayner, for having me here on this platform to share this conversation. So I have been asked to speak on the new direction that we are taking as far as presbyopia correction is concerned. So let's first speak about a few facts of presbyopia. We know today where cataract surgeons are more refractive surgeons, presbyopia is no longer going to be an option in the future. Screens are everywhere, devices are everywhere, and I think presbyopia is no longer going to be an option. Today, we have the options that we have to correct presbyopia include spectacles and contact lenses, of course, laser refractive surgery, and lens replacement surgery. And in the last few weeks, there has been some talk about eye drops, though, of course, this is a moot point. Now, let's talk about the economics of presbyopia. This is something that none of us really stop to think about. Over 1 billion people are affected with presbyopia worldwide, and the global costs associated with the correction of presbyopia is more than $31 billion US. That fact kind of stunned me. Presbyopes have reported a 22% decrease in their quality of life scores, and over 80% of uncorrected presbyopes reported moderate to severe difficulties in performing day-to-day routine tasks. So as we understand, presbyopia is a multi-billion-dollar industry and growing every day. So with that, I'm going to share a few thoughts on a new direction in presbyopia correction with emphasis on the new Rayner EMV lens. So what are the options we have for lens-based presbyopia correction today? As Dr. Stuart mentioned, monofocal IOLs with monovision have their own drawbacks. They provide a very good range of vision. However, the drawbacks are basically a depth in the decrease of focus, less than optimal, intermediate, or near vision. And there are gaps in the continuum of vision. Multifocals, of course, provide a very, very superior range of vision, but we all know the drawbacks associated with multifocal lenses, including optical phenomena like glare and halos. And the traditional early days of EDOF lenses, of course, provided for excellent distance, good intermediate, and very functional near vision. However, dysphotopsia was relative to the underlying optical technology. So traditional EDOF lenses that relied on diffractive surfaces still were associated with optical phenomena like glare and halos and loss of contrast sensitivity. So what is this new class of IOL technology? So different manufacturers are now using different principles in the manufacture of presbyopia correcting intraocular lenses. However, there is one common goal, and that is the optimal distribution of incident light towards one or more useful foci, with the aim of improving the intermediate vision and reduction in the unwanted photic phenomena. So basically, we're trying to provide a superior range of vision from far to near with minimal drawbacks by creating not a single focal point, but a focal zone employing monofocal optics, where light is not divided, but stretched, where you increase depth of focus. So what we do here, as I just mentioned, is we're creating an elongated focus instead of multiple focal points. So because we are not dividing the light, we are improving the contrast sensitivity and reducing unwanted photic phenomena. So everything is clear, but nothing is really in focus. And I think Dr. Alastair explained that with a beautiful slide, that as long as this blur is tolerable, the human brain can adapt and create a very useful, clear image. Now, modern EDOF technology, there are different principles. There is the zonal refractive, the diffractive, hybrid-based lenses, and anterior surface modification of the central optics. Other EDOF principles include a small aperture IOL and the bioanalogics. Okay, so let's come to what RayOne EMV has done. So they have a patented non-diffractive optic profile, which induces controlled spherical aberration only in the central area of the optic. So we're not talking about the entire surface of the lens here. We're talking about controlled spherical aberration in the central area of the optic. And in doing so, this increases the depth of focus by providing for a continuum of foci, minimal loss of quality of vision and minimal dysphotopsia. And all this helps you with much, much better and quicker neural adaptation with better visual outcomes and eventually higher patient satisfaction rates. Now, what are the key optical design elements of this lens? So the RayOne EMV has an aspheric anterior surface, which is aberration neutral, and a very unique patented inner optic design. And it is this inner optic design which induces this controlled positive spherical aberration, which elongates the depth of focus. And this extends your depth of vision. The blended zone on the anterior surface reduces the longitudinal spherical aberration and helps to maintain good distance visual acuity and good contrast sensitivity even under low light conditions. This one slide is very important to understand. So even with no offset, the RayOne EMV provides approximately 1.25 diopters of a depth of focus. So you have reasonably good far intermediate vision, even with no offset. And what this lens does is with 1 diopter of offset, which is what the company recommends now, it provides approximately 2.25 diopters of extended vision, depth of vision, which brings your near focus to about 40 to 50 centimeters, which is excellent in today's modern world for computers and tablets. So you get a superior intermediate vision when you compare this with the normal standard monofocal lens, available in a wide range of powers from 10 to 30 diopters in 0.5 diopters increments. So the features and the benefits of this lens include a smoother blended transition between the dominant and non-dominant eyes, maintaining binocular stereo acuity and reducing eye strain and asthenopia symptoms. This is very important to note. There is reduced pupil dependency for optimized performance in all light conditions, reduced sensitivity to decentration and tilt compared to other IOL designs, and it complements the eye's natural positive spherical aberration. So you can even target bilateral emetropia as a starter when you're starting with this lens. And if you're not confident, or you're not a fan of monovision, you can even start with bilateral emetropia, and that provides you about 1.25 diopters of depth of focus. Now, this chart shows you the differences between monovision with conventional monofocals and monovision with the Rayner EMV. As you can see in the lower part of the illustration, even with emetropia in the dominant eye, you get a depth of focus covering from distance to the far intermediate. You combine that with a 1 diopter offset in the non-dominant eye, and you get vision from the far intermediate up to the close intermediate. And when you put both the eyes together binocularly, when you summate the two eyes together, you get a very good depth of focus going right all the way from far to the near intermediate. Compare this with the conventional monofocal monovision, and you can see that there is a gap zone in between. So the dominant eye is targeted for distance, and the non-dominant eye for either intermediate or near, but there's always going to be a gap zone in between. And very often in certain patients, this gap zone is not well tolerated, and neural adaptation is more difficult to process. So this is a very versatile lens, and this enhances patient outcomes, as I mentioned earlier, even when you target emetropia, bilateral emetropia. With 1 diopter of defocus, with 1 diopter of offset, as you can see, there's a very, very good functional range of vision that's provided out here. Now, the defocus curve, as you can see, this defocus, the credit is this defocus curve has been plotted by Dr. Mariano Royo from Madrid. And it shows that even with up to 2 diopters of defocus, you get a fairly good visual acuity of approximately about 0.2 to 0.3 logmar. And I think in Europe, in most parts of Europe and the United States, a threshold of 0.3 logmar is a common criterion considered for even driving, for driving purposes. So with a defocus of up to 2 diopters, you can achieve a fairly good visual acuity of between 6.9 to 6.12. The MTF curve also shows like any a light transmission as good as any other monofocal IOL profile. So I'm just going to talk very briefly. We've done close to about 30 to 35 lenses at this point of time. I started using this lens approximately at the end of September. For purposes of this study, we've included 17 eyes. This is, rather than call this a study, I would like to say this is just my initial observations. We are still we're still gathering the data and analyzing it further. So we had bilateral implantations done in 14 eyes, that's 7 patients. Unilateral implants in 6 eyes, 3 eyes were excluded from the study. The mean IOL power was 20 diopters plus or minus 3.46, and the mean. So my first 20 patients, I am not a big fan of monovision, and it took me some time to get used to this concept of monovision. So I started off by targeting emetropia in both eyes. I am now progressing slowly to 0.5 and 0.75 offsets. And let's look at the next slide. So monoocular uncorrected distance vision, 100% of patients had 6/9 or better vision, with 83% of patients at 6/6 or better. That is as good or equivalent to any other good monofocal lens. The uncorrected intermediate visual acuity was N8 or better in 100% of patients, and this was really heartwarming to note. The monocular uncorrected near vision, surprisingly, in 8% of people, we found N6 vision, which was excellent, and 100% of this very small group of patients actually had N10 or better vision for near. Coming to the performance of the lens, these are very basic questions that we asked the patient. None of the patients reported any dysphotopsia, which of course was not surprising at all. And 100% of these patients were extremely satisfied with this lens and its outcomes. So where are we? What is this new direction that we are taking in presbyopia correction? This illustration, I credit Rayner for the material for this illustration. Very clearly shows on the left-hand side in blue, we have the monofocals. So as we move to the left side of the illustration, you have your monofocal lens with lenses with increased spectacle dependence. As you move to the right-hand side of the illustration, you have the multifocal lenses with relative spectacle independence, and sitting right in there, filling that gap, is the new generation of EDOF lenses, also the EROV or the IROV lenses. So the RayOne EMV fits this gap beautifully. Without any offsets, you move more towards the monofocal plus lenses like the Johnson & Johnson iHands, but with an offset, you're almost moving to near multifocal kind of performance without the side effects associated with this kind of a lens. So what are the key takeaways from this small talk? It would be, I would not like to end this conversation without crediting this lens to Professor Dr. Graham Barrett, who designed this lens. This lens gives high performance in visual acuity from far to functional near without the gaps that are there in multifocal vision, which are responsible for the dysphotopsias that we are all familiar with now. Fantastic performance of the contrast sensitivity with negligible glare and halos, high light transmission efficiency. Like I said, the MPF curves are equivalent to any good monofocal lens. There is an improved reading speed, very fast and very easy neural adaptation. In fact, there's practically no neural adaptation out here. The lens is very, very tolerant to fault. You have this very wide landing zone, so very fault tolerant. And one thing I would like to add is it comes on the RayOne platform. And I would like to say that this RayOne platform with the RayOne injector has made my life super easy. I mean, I would not like to say anything further unless you've tried this for yourself and you've held the RayOne injector in your hand, you know what I'm talking about. So I'd like to end this talk with one last slide. So in a modern world where cataract surgery is now more refractive surgery, what would I, as a surgeon, expect from an ideal lens? What would I define as an ideal lens? In my mind, an ideal lens is one that can give you the best quantity of vision, that is the best uncorrected distance, intermediate and near range of vision, with the best quality of vision, giving you good contrast with minimal dysphotopsias. A lens that can give me minimal dependence on external optical aids. A lens has stability of vision over time with low PCO rates. And of course, a lens that's cost effective. And I think with this generation of lenses, with the Rayner EMV, almost each and every of these boxes have been very well ticked. And I think, are we at perfection yet? No, we're not at perfection yet, but we are getting pretty damn close there now. So as they say, a journey of 1,000 miles begins with a single step, and we are well on that journey now. Thank you so much for your attention.
Thank you, Dr. Ryan. I think that was a wonderful talk that you gave us a real journey, your journey with these lenses. And as you have said, that are we in that journey where we want the best in quality, best in quantity, and of course, the surgeon should be free to use those things. I mean, there should not be after removal of the cataract, well, what goes wrong with the injector system. So we have this, I'll be talking on the reliable and predictable delivery system. So this is, we are talking, as Dr. Ryan just said, that you need a very easy injector system. I mean, a lot of us are, or most of us are now using disposable injector system. We have moved away from those lenses where you have to load it yourself. I think this is something, a revelation that we had. Just I have this slide from Rayner. This is the patented lock and roll. Those who have not used it, I think you simply jump to use it. Now, this is a little short video, and then we'll be showing it actually live. Now, look at this, the ergonomic design, how we handle it. The two-step, easy step where, just put in, most of the time, even we don't put this OVD, as I'll be showing in our own, but you can put this OVD, just lock it, and there it is. There, the patented lock and roll technology, the consistent delivery system, and it folds by itself. Unlike in some lenses, you have to push in so that the haptics don't curl. They curl over each other. You have to help it, but here it is a minimal force to the plunger, and the lens goes in the smallest of incision. We are using around 2 millimeter or 2.2 millimeter incisions, the lowest, but this is something which goes to 1.6. This is a 6 millimeter lens, it's like a bulky haptic, but still they managed to put it right there. This injects almost 20 years, whether it was the earlier form of the lenses, and we know this Apple, this. So this, we just show you the actual loading. As you can see, this is just peel off loader. It is under ESS. You just take it out, and you don't need to, even without putting in any viscoelastic, you can just push in and the lens goes right in. And just, this is under irrigation. As I'm showing the side view, I'll be showing where we put it through visco and even through the irrigation on. That's it. So this is one of the case where a small pupil, as you can see, we've just stained it. This is the B-hex, the pupillary expander. We use a forceps. One of our close friends, Dr. Suben Bhattacharjee, was the one who has got it in. I'm not sure whether it's available in UK, but this is the one. You can just, it's a single planar, small wear like, and you can just get that in a very tonic pupil also. There, you can just place it, right? It goes behind the iris. Once you have got this, we've got around 5 millimeter rexes, and just going in there. This is a hard cataract. Just go in with our chopping, and can go in. The whole idea is that you have got a small pupil here, and how do I get this once by manual IA? This is, see, I'm putting it under irrigation. There, the lens goes in slowly, and just beautifully controlled. The lens is there. You can, and even in presence of that B-hex, you can just tuck in the lens in that, even that smaller. We didn't get around 5.5. This was around 4.5 millimeter rexes, and this is again a device with which you can just hold it in one hand. Just this irrigation is on. You do not put any screw. Just get it round and get it out. A similar small pupil. This is one, the flax. Again, it's still smaller. This was around 4 millimeter rexes. I just got that B-hex in, and the same way, just tucked it in the second plunger, and the same thing goes with the third one. And just plunges. It's cheaper than the Nivean is my second choice. The first choice used to be first choice till this device came in. And this is again a softer cataract. We just go ahead with the emulsification. And in this case, we are putting it under visco. As you can see, I put in the methylcellulose viscose, and then see the lens goes in slowly and surely. You can take the plunger right there because it's just 1.6 millimeter, 5 millimeter. So it's up to me, and then just tuck it in side bag and remove the visco right in front and behind the lens before you go ahead and remove that small little device and perhaps nice round pupil. So just a small experience of patient that we had both the eyes done, just getting that distance. You can make the patient read distance, intermediate, and get in. And the contrast is also good. Thank you. Thank you for your attention. So here we have the lens that we have. I think we have some questions here. And anybody would like to comment on anything that we had amongst the panel, because we do have some open questions here. As the Rayner EMV has a range of focus, any comment regarding the sharpness of image in comparison to monofocal IOLs or distant? Dr. Stuart, you have had experience for a long time now. So about the sharpness, they are asking on the contrast or the sharpness that we see.
Sure. The contrast vision of a distance focused eye is exactly the same as you would have with a standard monofocal. There's no degradation of quality whatsoever. Yeah, that's a simple answer, basically. That's through my anecdotal experience, but it's been replicated through my colleagues too. The contrast vision doesn't drop. So there's no concerns about a patient having to compromise their distance vision with an EMV compared to a standard monofocal.
And there's a follow-up question by the same Dr. Neeraj Gupta. He says that should we check the corneal aberrations before considering Rayner EMV? I mean, is there any need for that?
I think that's an important point. I think generally speaking, if it's a virgin eye that's not had surgery before, probably not. I personally do it for all patients because I'm interested and I think it's good to know what the patient brings to the table. But really, when you're starting out with that, I think that the only consideration you need to have is patients that have had previous refractive surgery. So then you're likely to have already shifted the dial for the spherical aberration quite a long way from what would be nascent aberrations. And if you then induce further positive spherical aberration to an eye that's already had it driven up by a laser procedure, then you could run into trouble and get into that toxic level that I was referring to earlier. So I would say, in summary, for virgin eyes, you get away without measuring it, but certainly if it's patients that have had refractive surgery before, you should measure it before using the EMV. And I'd be slightly reticent at the moment to use the EMV in a patient that's had a refractive procedure before anyway.
There's a question again. Do we have to take into consideration, Dr. Ray, and you have done quite an angle kappa that we do in typical bifocal or a trifocal lens? Do we have to consider the angle kappa?
So since this lens, typically its profile, it behaves like a monofocal lens, angle kappa is not critical to its implantation, to the implantation of this lens. I wouldn't want to go in extreme cases. So I would use in a case where I suspect that the angle kappa would be larger, or in a case where I feel that there would be an issue with decentration or tilt of the lens, then I think the same principles would apply as with any other premium intraocular lens. I think this is no different from any other premium intraocular lens, whether it's an aspheric monofocal lens, whether it's a trifocal or a bifocal lens, or whether it's an EDOF lens.
Dr. Nivean, I think you would answer that. How do you compare this with the eye hands? I'm sure you must have had quite a bit of experience.
Actually, I have a very limited experience with eye hands.
Anybody has it, because we have also used a lot of eye hands, but definitely.
But I've used a lot of mini-well lenses from Sifi, Italy. So yeah. I think again,
but then this is definitely better than eye hands. And
I think they work differently.
Still, this lens was available. We were using a lot of eye hands, but then once this has become available for last couple of months, and again there is a question to Dr. Stuart from Dr. Tello. Does this induce negative spherical aberration? Because we are putting in, I'm not very clear, because what we are doing with these techniques and the Alcon IQ and everything is we're just bringing in, taking care of that positive spherical aberration. But here we are inducing more spherical aberration. So what do you have to say on that?
It's most definitely positive. All Rayner's documentation suggests that to be the case. And from my anecdotal evidence, I've been doing Osiris aberometers pre and post-op for patients and trying to pull out exactly what this lens is giving patients. And it's most definitely positive. As to how much positive it gives you, that's still, I'm not sure yet. And it will be different as well. You have to consider that across the power range of lenses, you'll induce a different amount of spherical aberration. But my kind of feeling about that is that it's going to move the dial in the right direction, and it's not going to take you into that toxic level if you've got a patient that's got a virgin eye. So it's most definitely positive. And as I say, you don't need to worry too much with a virgin eye about them going too far.
Yeah, there's one more question. What would be the effect if you have a plain monofocal in one eye and this time? Dr. Nivean, you have used quite a lot of these lenses. Again, if the patient has a simple monofocal and the other eye has a Rayner EMV, would it make any difference for the patient's image quality or anything?
So I have a basic principle that I don't mix and match, because I think many surgeons have tried it. I think you have to be braver, but according to the neural adaptation brain, it's always better to have the same type of thing that you do in one eye to the other eye. But that's my personal opinion, actually. So anybody else have tried anything like that with the other lenses can share the experience.
Dr. Ryan, again, Ryan, I think this question would be what you would answer. How would you categorize this lens in EDOF spectrum? Because you've given that beautiful image. How do you compare it the Vivity lens or the Symphony lens versus this one?
So I was the one who wanted to ask that question to Dr. Alastair, actually. So there's a lot of confusion regarding this terminology EDOF. So you call the Zeiss 80 Lara, the Symphony, the Synchrony, the
Vivity. They're all Vivity, in that big group.
They're all, even the iHands, they were all called EDOF lenses at one time, and we seem to be using this terminology very interchangeably. So is there anyone who is actually categorizing or classifying these lenses now? This gap between the monofocals and the multifocals seems to have been filled in with this broad class of EDOF lenses. So is there any way to define these EDOF lenses? So I think if I remember hearing one talk, I think Dr. Alastair was on that panel where they mentioned about monofocal plus and IROV and EROV and EDOF adding to the terminologies out there. Yeah. So I think all these lenses, whether it's the EMV or the Vivity or the iHands, all these lenses are principally doing one thing, if I understand right, and that they're stretching the point of focus. So they're employing different optical principles to do so. What Rayner is doing is it's employing the principles of measured, controlled spherical aberration in the center of the lens to stretch that point of focus. The Vivity has a different principle, but it's also doing the same thing. It's stretching the point of focus and shifting it. So I think all of these basically are now increasing your range of focus. Strictly speaking, if you want to define things, then even a multifocal lens is an EDOF lens because it's extending your range of focus.
Exactly, Dr. and Stuart, I think it's become very confusing. And I think EDOF itself has become an umbrella term for a lot of lenses, and it becomes quite confusing. The Symphony lens can be put in the EDOF group, but that works in a completely different way to the EMV. The important thing is, as you stated, is about the spherical aberration induction. That's what separates this and a couple of other lenses from the other EDOF lenses, and that's the important part, because from what we know with Presbyon, with Zeiss's laser blended vision platform, that's the same optical principle. We know that doesn't come with the same levels of night vision problems, reduced contrast, and tolerance issues. So that's the thing to split up, is the ones that use spherical aberration and those that don't. And then, well, Rayner needs to come up with a term to isolate their lens in that regard.
Yes.
For a lay surgeon, I think it would be, are these lenses with rings or without rings? I think That's I mean, the rings are the ones which would split the light and definitely lower the contrast and increase this photopsia. And these are the lenses, group of lenses where they don't split the lens. The rather the focus is large, so you have lesser. I haven't faced anything extra this photopsia with the 30 odd lenses that I have used. Either the eye-hands I have used quite a lot, and this new focus of lenses, this new group of lenses where the central part of the lens optical, change something. I mean, the company propriety as both with eye-hands and this lens, even in the riveting, they're not very clear what they're doing. Unlike the trifocals where you have a real phase diagrams where you have these are. So I suppose these are the group of lenses that we'll be having more and more.
Yeah, you hit the nail on the head there, Dr. Paul. This lens is not diffractive. That is the key.
Absolutely.
Yes.
As to what to give, what name to give this lens, it's not diffractive.
One more common question that comes up with these group of lenses that we have been seeing for last year or so since eye-hands was launched. Can we give in how much the astigmatism with this lens tolerate? I mean, what would be your cutoff? Is it just like the trifocals or bifocals where most of us would do 0.5 or 0.75 for a norm, because we don't have the toric formulation in either the eye-hands or this lens. How much astigmatism? Is it the same as the trifocals or the bifocals that we are using, a 0.5, 0.75 or something like that? Or does it tolerate, or does it stop working, that the intermediate vision? Dr. Stuart, what is your experience?
So my target for the near eye comes off the back of my experience with presbyon. So generally speaking, the target for a presbyon near vision eye is -1.5. And so knowing that when you have spherical aberration incorporated into that system and you don't get problems with tolerance, I was happy to start off with the -150 near set eye from the get-go. I'm not sure I'd recommend that for everyone. I can understand where people would have a little bit of resistance towards doing that. But I think it was in Dr. D'Souza's talk, you lose nothing by starting with plano for both eyes. You have absolutely no risk there whatsoever. If you're a cataract surgeon who's doing monofocal set for distance and asking patients to wear reading glasses and you switch to the EMV, you've got nothing to lose and everything to gain, because your patients will suddenly get a good level of near vision. They'll be able to read a newspaper in good light. But if you want to take that a step further and really aim for getting patients as independent from glasses as possible, that's when you start needing to incorporate some anisometropia into it. And you can work your way in. You can start with -0.5, then go to -1. You don't have to go to -150 straight from the get-go. I only was able to do that because of my experience with presbyon. But just work your way in. Start small and work from there.
Again, Dr. Nivean, you showed some glaucomatous patients, but is there any macular pathology that would have any macular, early diabetic retinopathy or some sort of maculopathies? Would you put these lenses, or would you just go, no, I don't want to take risk? I mean, is there any contraindication for it?
Broadly, I think being a retina person, I think any macular pathology, I think any multifocality or this thing may not work properly.
Because we are not classifying it as a multifocal. That's the.
But still, it may not work up to the potential of the particular technology or the lens. But it's forgiving because maybe the patients, because sometimes when you have macular pathology and you have the multifocals, it can actually reduce your vision and hinder it further. Maybe that this lens may not do. I don't have experience. I think they have to it behaves like a monofocal. So you're not actually, the vision cannot be reduced further, at least.
I think it's a really interesting point. I think we at the London Vision Clinic have as I say, a great deal of experience with presbyon, and we've had patients who have gone on to develop macular problems, as so many people will. And we've not found anecdotally that having spherical aberration inducted in your cornea then leads to the problems that you would get if you put a multifocal in someone that was 50 and then developed ADML later. So based on that theory, I would be comfortable putting an EMV lens in someone with macular pathology because it's not diffractive.
I think Dr. I would.
Ryan, will decentration affect the performance of the lens? I mean, you have a rexis which is not right central, or you have one side is runaway.
Okay, so
you put this lens.
Yes. So whenever you have a situation that's anything less than ideal, whether it be potential for decentration or tilt say a zonular dialysis, or for that matter, as you addressed earlier, any significant amount of astigmatism that cannot be corrected, then I think it is best to avoid any kind of premium IOL technology, whether it be an aspheric lens or an EDOF lens or a multifocal lens. Having said that, since it has been well demonstrated in early studies now that these lenses have a defocus curve that's better than a standard monofocal lens, and an MTF curve that is as good as a monofocal lens, I do not see any reason why you cannot put in this lens in an eye, in any eye that you can put in a monofocal lens. So in my practice, I think I would definitely put this lens in any eye where I will consider putting in a conventional or a standard monofocal lens. The only exception for the moment being a level of astigmatism that I cannot correct. Say for right now, I would keep my point at about 0.75. I do believe Rayner is coming out with a toric version in the first quarter of the next year. And I would probably have certain reservations in the beginning using these lenses for very high myopic LASIK corrections. In eyes that have had very high myopic LASIK corrections, because these eyes already have a lot of positive spherical aberrations. Absolutely. So I would certainly like to understand the spherical aberrations of the cornea. But I think this applies with any premium lens technology.
Absolutely. I think that's very well said, because since we are considering this as a monofocal, so it's a better monofocal and advanced monofocal. So any place that, that's what I have been doing. I've had a lot of patients with, quite a few patients with macular pathology, and then quite a few patients over the last 30-35 lenses that we have put in. So we haven't faced anything. I have put in up to one diopter of astigmatism with an LRI, and it's working fine. I mean, patients are getting near vision. Yes. Rather, the lady that we just showed was a patient where we put in this was 2 weeks back that we put the second eye, and she is doing absolutely fine with the LRI and the steeper axis. We are given incision.
Yes. I think one more point to add. Sorry, if I can add one more point. I think because this lens has a very wide landing zone. It has a zone instead of a focal point. I think it is much more fault tolerant. So you can actually end up with a situation where it will tolerate a better range of refractive error than even a conventional monofocal would. And since the amount of spherical aberration that we are talking about here is very, very small and measured, and in the central zone of the lens only, I do believe that this lens will be very, very well tolerated in almost any situation. I would like to share one small thing also, and this is how I integrated this lens into my practice. So, in the beginning of time, I would, patients with monofocal lenses, no matter how well counseled they were, when they came in for their follow-up, their first complaint would be, I can't read. Absolutely. No matter how well that they were counseled, their first, even if they had perfectly good distance vision, their complaints would be, I can't read. Now, a decade ago, multifocal lenses changed a lot of things for all of us. However, that multifocal lenses came with a lot of trade-offs that we're very familiar with. And I think this group of lenses has perfectly well filled that gap. So, as Steve Jobs famously said when he introduced the iPad, that we had an iPhone and we had a Mac, and the iPad fit in so beautifully right in between. I think the EDOF lens, the Rayner EMV, fits in beautifully in between the monofocal and the multifocal. And I see in the very, very near future, my practice having almost no monofocal patients. I think almost every patient will be shifted to the Rayner EMV lens. And probably in the future, I see a scenario where this technology, when it matures further, will even replace the multifocal lenses.
Yes, Dr. Ren, very well said again. I think it was wonderful. I mean, placing the lens and where do you put it in your practice and how do you counsel the patient. And you're absolutely right. I mean, if you add that near vision a little bit, and today with these, the smartphones which are there, especially these last 2 years, where everybody is glued to their this near vision, all these gadgets. So this has come as this will be a game changer probably, how we do it. And I think there was one more question. I think it's too early to say what is the PCO rate, but then it should be the same as the Rayner. I mean, the Rayner has been proved as good as AcrySoft, 3 to 4%. This is unlike the other 15 to 20% in any other lenses, hydrophilic lenses. This compares well with the I suppose this should be the same. There's no profile change in the lens with the Rayner C-Plex or the Rayner S-Fric that we had earlier. So it's basically the central part which a little bit change is there, but then the square edge and everything is the same. So I suppose this should be having the same. Any comment on that, Dr. Stuart, on the PCO rates that you have been using with the Rayner over the years?
My experience with the Rayner monofocal is pretty much the same as the RayOne EMV, in so much as it's too early. I've only been using both lenses for 2 years. So until we get to the 10-year mark, not easy to comment.
I think, sir, generally itself, the Rayner material and technology, they have a lower PCO rates, is what I see. And they also have these haptics. So and I have this thing that it doesn't matter only on the lens. It is about the surgery. It's about the rexes.
Absolutely. How you clean up your...
Factors that are also playing a role on the PCO progression.
Dr. Paul, I've been using these lenses for the last 20 years, the Rayner lenses. And I think after the introduction of the RayOne series of lenses with the enhanced 360-degree edges, square edge technology, I think the PCO rates have significantly come down. And as you rightly said a moment ago, I think it's now on par with the AcrySoft lenses.
Yeah, that's true. I mean, AcrySoft is considered by the industry or the doctors as the gold standard of how much that's especially the study by Jack Holliday and everybody, David Apple, where they showed that around the standard would be 2%, but then 4% is acceptable. I think that's the range that they're doing. I suppose we are off. We don't have any more questions. Is there any more fresh? Can you see? No, that was the last one. Any more comment any would like to before we wind up? I think we are well within an hour. We're supposed to be in 45 minutes, but then we had so many questions that we answered.
Can I ask the panel one question?
Yeah.
Does anyone have any experience with putting a sulcoflex lens in with this lens?
Over this lens?
Yes, over this lens as yet. I think it's too early days, but does anyone have any experience?
Not. They've been very... Probably we didn't have any. I think the range of lenses, I suppose I saw it +6 to 30, I suppose. If you are putting anything above that, maybe we might end up having that. Anyway, thank you to all my speakers here, Dr. Stuart, Dr. D'Souza, and Dr. Nivean. And thanks to Team Rayner for having us all together, having a lively discussion, discussing our early experiences. Most of us are early experience, and this new technology, the way to move forward, I suppose that would be the way we'll be moving, as Dr. Ryan says, that probably we'll do away with all the monofocals. This would be our monofocal, and then if there is an improvement in the trifocal technology over here, but this would, as has stayed before EMV came, it was the eye-hands which was there, but see, one step going further forward, and it's so easy on the pocket. So it's not that costly. You can just add a few cents over your the surgical charges that you do for monofocals. Thank you. Any comment from the team, Rayner? Yeah.
I just want to say thank you very much to all the speakers, and thank you to the audience. I think this new kind of category of lens is obviously extremely interesting for you all, and I look forward to seeing some of you in person in India in the coming months. And yes, that toric is coming. Maybe not quite in Q1, but if we can get it there in Q1, we will do.
Thanks a bunch, Dr. Stuart, Dr. Ryan, Dr. Nivean, and Paul, sir, for wonderfully moderating this session. And thanks from Team India, Rayner.
Pleasure. Thank you, everyone.
Thank you.
Good night.